All right. So today I want to talk a little bit about the dichotomy of when patients come in for lower back pain or stuff going down the leg, of when we really pay close attention to the lumbar findings, or mostly the lumbar discs when they have MRI, and whether or not there's some anterior listhesis. Suji, I just wanted to share how I put that into my thought process and how I use that to educate the patients. Okay? So I wanted to bring this up because I just got finished up with a student recently. And of course, students always bring in good questions, and they really force us as clinicians to kind of better organize our thoughts and to be able to describe it so that some of our thought process either clean it up or be able to communicate it in a way that it's reproducible for them to take these abstract concepts and put them in to their own thought process. So we know as people age, there's definitely a normal aging process of the lumbar intervertebral discs. Yeah, so there's all sorts of different pathologies that are named on radiologist reports in terms of Schmorl's nodes and modic changes and disc protrusions and disc bulges and annular fissures, to name a few of them. So anyway, when I was doing the Institute program with Martin Langus in Woburn, Massachusetts, him and his mentors and all the people that he had worked with had noticed a pattern, and now more recently there's been some literature to suggest that there's further evidence kind of showing these changes that they had noticed with their kind of chronic or acute lower back pain patients. And that when we're younger, the intervertebral discs in the lumbar spine, they have more of this kind of Dr. Scholl's type gel pad sort of texture to it. They absorb a lot of force, and then in cadaver studies where they cut the annulus fibrosus in a younger individual, and then they go to like bend the spine to try to push the jelly out of the disc right there. It doesn't particularly move. It'll stay right there. Well, as we see, once people get closer to the third decade, and again, there's no cutoff point, but as we get closer to the third decade of life, meaning in the 30s, the consistency of that disc starts to turn from more a Dr. Scholl's into more like wet feta cheese. Okay. So the issue with that is now it's able to be kind of displaced a little bit more, and it can start to it doesn't have the same kind of weight distributing properties that it did, but it still doesn't mean that it causes pain. We just want to keep this in mind in terms of these are some normal aging properties of the disc. Okay. And it's theorized that perhaps when it's in that wet feta cheese type scenario, that it can now start to move into these annual fissures. I don't know if we don't know for sure if that's reasons for pain. It's probably just an adaptation that occurs, just like as if we see the wrinkles in our hand for the most part. All right, so we got all these folds, and so when we go to bend our hand, it allows us to move in that way. So the strategies that we use within our body often are probably going to show some physical changes on images. We see it in our face when we smile. When our eyebrows go up, we get the wrinkles. So often I try to educate my patients in that way, being like, hey, you've moved a certain way for many years and many decades, and it's really no surprise that we would see these changes or these kind of folds in your back as just adaptations from you and the strategies you've used most of your life. Doesn't mean you can't learn a new skill and learn how to bend and move in different ways or be able to distribute forces differently. But it's not doom and gloom to say that there's some disease occurring just because you now had this presentation of these changes on an MRI and you've been given this kind of pathology or disease diagnosis, okay? Because we really don't know, and I'll link the article in the notes here. It's very difficult to discern the difference between normal aging characteristics of the disc and like a pathologic injury to it. But sure, there's events and injuries, especially we think about some very big forces, like motor vehicle accidents, that can absolutely create a disruption or an injury with trauma to those structures. And yeah, we do need to respect that. There are also times where we have, maybe a strain or a compromise under repeated load to those structures. And that's where I wanted to dive into where this article from 2015, I'll link as well. So in any case, what we find is that in younger individuals, so around the 30 or even younger mark, so when we find changes of mostly like a disc bulge, we see is that typically the younger population, when they have that finding on MRI, that statistically they're more likely to be symptomatic. So that means that the chances of having a finding where you have a disc bulge when you're getting closer to your 50s and then definitely into your 60s, most people are going to have those changes. But the rate of being symptomatic with those changes drops off considerably. So it's not really doom and gloom. We don't want to be, telling patients, well, geez, you're going to have this spine that has this degenerative process, and now you're just starting early, so you're going to have a lifetime of back pain. Okay, I don't know if we really want to be telling people that, because then their chances of getting better are pretty low because they trust you. And if you say that to them, then, well, that creates a lasting memory on their brain. So anyway, we don't want to totally just put to the side that there is no pathological changes or there is nothing that we need to think about or consider when we're talking to patients about this. But often what we'll see is when younger people, meaning like teenagers to, early to mid 30s, is if they have either a sudden onset of lower back pain from an event, and or if they start feeling stuff going down their leg from being in prolonged positions, or doing prolonged heavy activities, it seems like that leads to a little bit of a longer recovery at times than, let's say, if it was their counterparts at a little bit of an older age, where you see people in like their 50s and 60s where this pain kind of slowly comes on. It's been there for a little while. We treat them, and then it pretty considerably in a little more of a linear aspect makes its way into feeling and having less pain, and people feel better, and it seems like it makes a little bit more sense. But so again, with that younger population, and it's not necessarily that we need to have people go rush to get MRIs when they don't have any other red flags. But we do need to take into consideration they do have a disc that changes, that has a little more fluid to it, and if it's their first kind of anatomical compromise, then maybe some chemical changes happening at the disc or in that region that can just kind of increase the input into all the innervated nerves in that area that can send a signal of kind of fight or flight to the brain, leading to an increased risk of pain. And again, that is no guarantee. Pain is a confusing thing, especially to me. But saying that in theory, as we want to educate patients so that we don't put off the fact that they have findings on their MRI that maybe they're worried about, and then us just kind of saying, hey, that doesn't really matter. There's a lot of research that suggests that, lots of people have, herniated discs or disc bulges, and, it doesn't really matter. That's not really, I don't know if going that avenue is the greatest way to get trust and buy-in with the patient, but rather being able to change the context with evidence that we have to say, hey, I get what you're saying. Look, we can pretty much pencil in if we can stay decreasing these aggravating factors that you have to do on your daily basis. If we can reduce it, below a certain threshold to allow you to recover, and then as you feel better, we can start increasing your work capacity again. Yeah, you can pretty much pencil in 3 to 6 months that you're going to be feeling like a much better version of than you do right now. And as you go along the way, you're going to feel a little bit better as you go. But don't be worried when you have a day that just doesn't go well and you're not sure why, even though you've done everything that the therapist has asked you to. We have to reassure the patient that they're going in a good fashion, and what they're experiencing at this point is normal. Right. So if they're starting to notice some activities like getting up from a chair or rolling in bed, or their neural tension changes, or their myotomes get better, or their reflex comes back, if all those things are going in a good direction, then just because they have the same intensity of pain on some days, they kind of need to understand that what they're going through is normal. And then as we get to some of the older patients, it seems like they can be a little bit more on a steady beat towards a better outcome. And they don't seem to respond as well to changing ergonomic factors as quickly as some younger patients. And they seem to respond really, really well to improving their movement variability, improving the robustness of movement options that they have, instead of just continuously pounding the same way that their back folds, and giving them another option. But it seems like that's kind of the pattern we've been noticing at the clinic. Okay, so in summary, I think I touched on a few different things, but just in summary, when we have younger patients, whether they have or have not had an MRI, and by younger patients I mean from their teen years to probably early 30s or so, we need to let them know that this is going to be kind of a long haul, and that when they have their bad days, to not be fearful that somehow something's been missed, as long as their neuro changes are not getting worse. In fact, they're getting better. That they're noticing increases in activity tolerance, and that and as long as they don't have any of those red flag findings, meaning like pain going down both legs, obviously, and those bladder changes or sexual functional changes. Obviously those are immediate. They need to be out the door getting images. But for the most part, if they're noticing they can sit a little bit longer, walk a little bit longer, sleep through the night, not have as much pain when they wake up, that's normal stuff. They have some more fluid in their discs because they're younger, right? So they're going to the amount of the change of kind of their ability to distribute forces went from a really, really high thing to it's probably now filled with some inflammatory proteins at this point, and now their ability to do is just not as good. And then just the opposite for someone that's a little bit older, right? Where we need to get them to understand, hey, you got to use your own changes in intra-abdominal pressure. You've got to be able to kind of get these exercises down to dry up some variability changes, take some pressure off the usage of those the strategies you've been using for a long time, of those folds in your back there. Okay, so that's my thoughts on it. Let me know if you got any questions or anything else like that, or anything I can do to help you out. All right, take care.